So good afternoon, everyone. I'm Dr. Gordon Schachter. I'm a family physician here in London area, and I'm the clinical lead for primary care for the Middlesex London OHT, and I'm an executive on the Middlesex London Primary Care Network. So I just want to welcome you today if you've not been to one of our webinars before. Today, we're going to have speaker Dr. Noah Ivers talk to us about primary care teams. Why now? Why me? What's next? Just a few housekeeping items I just want to go through first. Make sure my slides are going to move here. There we go. Just want to put a plug out for a primary care symposium that the Middlesex London Primary Care Network is putting on as of October 1st. Full day event, 6 main pro credits, fairly inexpensive when we look at it. For our main pro credits for $40. September 1st is your early bird date, and I think afterwards it's 45 if I remember right. Good opportunity to get some learnings in, but also understand really what are the supports that are available in our community for providing good chronic disease prevention care. So if you want to and are interested, you could scan the QR code, but also we know we are advertising regularly on social media as well as our email blast from MLPCM. So please consider attending. It should be a good day. Just making sure everyone's going to have a good experience today. Make sure if you're not speaking, please keep your microphone on mute so we don't get background noise. There is a raise hand feature in Zoom, and we'll ask you to do that if you would like to ask a question out to our panel or Dr. Ivers. There is the chat that is available, and if people want to put questions into the chat or have some commentary in the chat, feel free to do so. We're going to ask Dr. Ivers to take questions at the end. Myself will probably monitor the chat and maybe summarize some of those questions and bring them forward because sometimes we find there is some general themes. And if there's something I can answer easily in the chat, I will do so along the way. If you're signed in as an iPhone, can you please rename yourself using the Zoom? Otherwise, we don't know who you are and we would not be able to give you your main pro credits, which this talk is accredited for. And lastly, we're just asking people to sign up for the MLPCN newsletter if you've not done so in the past. And this was on the website down below, as you see, the mlpcn.ca. And also, this meeting will be recorded. And so the recording and the slides will be available at a later date if you want to go back and look at what you've learned again to check some things up. Just some brief update on the MLPCN. So the MLPCN is really trying to be your advocate for the healthcare system. The PCN is formally funded through the Ontario Health Team via Ontario Health. It represents family physicians, nurse practitioners, and all that have a stake in primary care. And this is sort of our sort of statement. Rather than me reading, I'll just get you to take a look at it in detail. Our learning objectives for today are understanding some frameworks, how we might define good primary care, review the evidence for teams and increasing capacity in primary care, and discuss how to apply that evidence for your own practice in your own context. Dr. Noah Ivers, he's given us that he has no potential conflict of interests, and he does have some relationships with industry and for his research that he does. So I'm just going to take this down and introduce you, Noah. Let me just end the show there. Stop sharing. So Dr. Ivers, he's a family physician at Women's College Hospital Academic Family Health Team. He also leads a research program in implementation science at Women's College Hospital. He's a full professor in the Department of Family and Community Medicine at U of T. He holds a Canada Research Chair in the implementation of evidence-based practice. Noah's research focuses on the use of data to drive evidence-based, patient-centered improvements in healthcare. He has conducted multiple pragmatic randomized trials, systemic reviews, and qualitative work on health services and quality improvement interventions. Most recently, he has consulted with Health Canada on understanding how to apply evidence for team-based primary care and with Ontario Health to understand the effects of the most recent investments in primary care. So I will pass that over to you, Noah. Thank you. And make sure you
All right.
Yeah, great.
You can see the screen? Good
Yes,
stuff. Okay, so Yeah, the most important part of introducing me was missed there, but thank you, Gord. That was really nice. First of all, I'm a dad to two sporty boys, and so I spend a ridiculous amount of time driving them to, baseball fields or soccer fields or hockey rinks. I spend a lot of time behind the bench as well at the hockey rink, and I also have a daughter, but she's four-legged and furry. Hopefully she won't interrupt us during this meeting. Um, so yes, that's me. I want to jump in, but just a few more specific conflicts and caveats to talk about quickly. I do work in a team, and so I admit my bias there. It is so amazing that I could go away with my family last week and my colleagues could cover for me because and then, I owe them the favor back. And it is true that I have, a nurse shared with multiple of us, and admin staff and so on that we can delegate some tasks to, and that makes my life so much better. So that does bias me in this discussion, and I admit to that bias, but would love to talk more about it. Uh, I'm sorry to say that I am affiliated with U of T. I did, however, spend 7 years living in London and surrounds, and loved it. And although I am an academic, I know I look young. I've been seeing patients for 20 years now. So I do have some sense of what life is like, at the ground floor, at the coalface, etc. And while absolutely I get what it feels like to be burnt out, when I have a good night's sleep, uh, which is rare, but when I do, I actually feel motivated by the challenge of being a good doctor, because it's kind of, impossible to, do all the things amazingly well, but that's kind of what the challenge is all about. So, with all that in mind, now you have a sense of who I am. Let me tell you what I want to say for a little bit. Oh, there was one more thing to do, I think, and that just a little bit of a quasi land acknowledgement thing. This is a piece of art. You can see the artist labeled there. It's called Good Replacing Bad. And I just thought it was really, really thematic around, moving from um, a way of practicing that has us all kind of pulling our hair out to perhaps a way that feels more sustainable. All right, cool. So the context you guys all know. I just want to paint a bit of a picture with you though, because I think it's helpful. We know that comprehensive longitudinal primary care matters. It matters at a health system level. It makes the health system more efficient and effective. Population health is better where there are good primary care systems. Um, we also know it matters to patients. Like patients appreciate continuity. They appreciate being able to see us and so on. So, it's really, really important, but it's also harder than ever. Patients don't stay in hospital as long as they used to. They're more complex. There's a million more people with, multi-morbidity seemingly every second. Our job is not what it was 30 years ago. And so this is what the usual care model looks like. It's not what it should look like, but this is kind of what it looks like. We have these frequently frustrating, if you look down at the bottom, interactions with our patients that are like, I can only handle one thing at a time. And that's kind of because, the patient doesn't come in prepped. The, the team isn't ready for the patient. And the whole system above that interaction isn't set up in a way that gets them ready for that interaction. We feel the lack of leadership. We feel the lack of IT. We feel the sense that there's nobody else trying to direct the patients to an efficient way of doing things. They go to emerge when they shouldn't, and so on and so forth. Not to blame patients, that's a horrible thing to do, but there's just no system. And so the usual care model is frustrating. And so something's got to give. And this is another way of looking at it. This is a lovely paper from Canadian Family Physician. It's not my paper. I wish it was. We had these long-standing challenges. This slide is actually quite old. It's pre-pandemic. It's from what I call the before times. So there was already problems. And then we had the pandemic and we had the shifting of the workforce and so on and so forth. And now, it just keeps creating this negative feedback loop where it's becoming harder and harder to be the kinds of primary care clinicians that we want to be, to offer the care that we'd like to be able to offer. That creates moral distress. And so some of us leave, and then that makes it harder on the rest of us. You guys all know this. This is just me trying to, make you feel validated that what you're feeling is real. So, this is a funny way of thinking about it. I just wanted to show you this little video. It won't be long, but maybe you've seen this guy online. Hopefully you can hear the noise. Just give me a second there. Oh, I didn't know there'd be an ad. Hold on a sec. Sorry about the ad.
We're not seeing that, Noah. We're just seeing.
Oh, okay. Hold on. Let me switch the screen here. Thanks for telling me. I think it's worth just taking one moment to have a look. And can you see everything now?
Yeah,
Lord?
we're seeing
Yeah?
the small YouTube. Yeah.
Okay, great. Thanks. Let me just play that. Hopefully people can hear it. Let me know if you can't hear it, in which case we'll give up.
No volume.
Okay, we'll give that up. I'll send folks around the link, but basically it's a funny way of just describing how burnt out we are and how desperate we are for help, basically. So let me just make sure I'm sharing properly now. Hold on a sec. So we'll get back to it. Sorry about that interlude. So I'll just reshare the screen and we'll jump back into the details. Gord, we got the whole screen, right?
Yeah, we do.
Wonderful. Okay. So here's what the literature says. If we're working alone, it is literally impossible to do all the things. So, even if we ignore acute care, the sore knee, the sore throat, the, person in situational crisis, even if we ignore all that and we just do the guideline recommended preventative and chronic disease management, it's impossible to do all the things for 2,500 people alone. That's what this chart shows, but it is possible if we have a team. So that raises the question, if we know that, what does good primary care look like? And I like to think of the AAA acronym. I like to think that I can try to be accessible, affable, and able. But again, I can't do that without support from my team. And what we know from the literature is that when we have these 4 C's in a primary care practice and in a primary care system, we actually get better health system outcomes. These are those health system outcomes I was talking about before. This is from Barbara Starfield's work. And those 4 C's are listed here. So this is something that, we need help to achieve. But if we can achieve it, that's what good primary care looks like. From the patient's perspective, you would have gotten a lot about this from Tara, I guess, last week. There's also a set of ideals about what good primary care should look like, and that's listed in the Our Care project. And there is a bunch of overlap, actually, with those items that I listed on the slide before. I'm not going to read them to you just this moment. Just at the moment, I think it's enough to know that they exist. I want to dive in just to the first 3 for a moment and show you that the desires, the stated desires of the population, well, we're not really doing it. So we know that not everybody is connected with a primary care clinician. We know about that gap. That's been in the news. We know also that timeliness of access is, been a long-standing issue in Canada, not just for primary care, but for specialty care as well, when we compare to other countries. And again, not just to the States, but other OECD countries. And we know that if we think about primary care a little bit holistically, it often includes connections to social support, social services, things like that. And we don't do the most amazing job coordinating our patients' care because that's a ton of work and there's no systems in place. For instance, when I want to make a referral for somebody, I often, don't get mad, I refer to like 4 places at once because I have no idea where they're going to get in first. And that actually makes everything else worse and so on. But there's no system. So we're not doing a great job meeting the stated needs of the population, not for lack of effort. This all got worse during the pandemic, as I sort of mentioned before. And the science table asked us to gather some lessons learned from the pandemic in terms of where we did well and what that means for primary care going forward. And absolutely, people that were attached to teams did better in the pandemic. Teams were able to serve their community because they had some slack in terms of resources. And they were able to adapt to those needs a little bit more easily because they could cross-cover each other. And so what happened was we had this, starting in the before times, but exacerbated during the pandemic. Basically, oil went on the fire, and now the platform is really, really burning. We can't keep doing primary care the way we were doing it and meet the needs of the population or the health systems or, frankly, ourselves. Because it's not just the platform that's burning, we are burning out. And we're, voting with our feet. People are leaving comprehensive longitudinal primary care because it's not really sustainable to always do a little bit more for every patient all day long. We just can't. But we can start to imagine what a better day looks like, what a more sustainable work-life balance looks like, what a more rewarding job in primary care looks like. And this is from that same paper that I showed you, the image of from before that I said I wished I'd written. It's a lovely little diagram that shows how much happier, you see that happy face, the family doc is in this case, although it could be a nurse practitioner with their own panel, when they're able to work as a team, and most importantly, when they're able to share some of the tasks. And again, I don't think I need to read this to you, but the point is, if we can share the load, we can all sustain that load for a longer time. This just makes sense. And again, this is not a terribly new idea. We can move the idea that we can move from this, burdened guy on the left to this team-based approach in primary care has been talked about for quite a long time. It's just perhaps now is the time where finally, as I said, the platform is burning and we're actually getting some investments in the system with the potential to move. Now, not everybody will end up like the diagram on the right, where you have all these supports in place in one clinic. I think that's a pipe dream, but perhaps a lot of it could be in place, at least virtually, over time. So what happens from the research lens, though, if we're thinking about this? Will that actually help us solve the primary care crisis? Of course, it would be nice to share the load, but is there actually evidence from the research that will get more patients attached over the long haul to primary care? Well, we've recently done a synthesis of the literature, looking at this in a variety of ways. And we used the concept of capacity. What's the capacity for a most responsible clinician? That could be a family doc, it could be a nurse practitioner. In the States, it actually could be a physician assistant in some cases, and that's sort of, what happens if you add team members to them? in the literature to their, roster size, to their capacity. First of all, in the literature, a variety of team members were added, huge range of roles and tasks. And so synthesizing that data was difficult, especially because the way that they would have defined capacity varied widely in literature as well. Like, what are we really trying to do? Are we trying to increase roster size? Are we trying to increase throughput, like number of visits? Both? Something else? It's measured variably in the literature, and we have to come up with how we want to think about measuring it and what our goal is internally in a more specific way, I think. But regardless of how you measure it, I think what we see in the literature is that when you add team members, and this shouldn't really be a surprise, if you add team members, 86% of the studies reported an increase in capacity. A small number had a mix of findings, and a very small number actually reported a decrease. So it is possible to add team members and actually decrease capacity if you don't do it well, but that's rare. I don't want to go too into depth from those studies, but just to give you a sense of a flavor, we can look at the first line here. This is a study from 2011. They measured total throughput, just visits, and they added 1.5 nurse practitioners, and figured out the number of added visits that increased for the broad team. You can see there. So there's, just to give you a flavor of what's in the literature about how this could work. But of course, that depends on what you ask those nurse practitioners to do, and how the nurse practitioner ends up working and teaming with the already in existent sort of most responsible for clinician, and how they share tasks and how they work together, how they collaborate, and so on. And it raised as many questions as it answered, that scoping review. So we have embarked on a follow-up study to try to unpack in more depth what are the mechanisms by which adding team members, moving from maybe a smaller team to a larger team, or moving from a non-team to a team, can increase capacity. Like, what exactly ought to happen inside the team for that to work out properly? And this involves a big team, people listed there, because the literature is quite complex. In general, we know that adding people helps, but we wanted to understand, some of the actionable strategies to make that work well. So that's what I'll briefly touch on over the next few minutes. If we skip ahead basically to the results of that, what we are starting to unpack, and this is preliminary, is that the team members need to trust each other enough to carry out what we described as independent teamwork. That is to say, they share the load, they share tasks, they know what each other are capable of, and then they're able to each independently do those things. It doesn't help increase capacity if you do something and then I have to double check everything you just did, obviously. So there needs to be a sense of independence and trust for that to happen. But for that to happen, there needs to be active efforts to optimize roles, and sort of ongoing active efforts to team, to build trust, to get to know each other, and that sort of stuff. And that sounds really, really soft, I know. Like, we want the hard outcomes. But it seems like mechanistically, if you don't have that sense of trust with each other, that you can share the load, then you're not going to get that increased capacity. So some things definitely can get in the way that we identified in the literature as well. And I think some of you may identify with this: staff turnover, non-sustained funding, instability in the roles. Obviously, that can get in the way of that process that I described of building trust and sharing the load. I mentioned the need to be clear about what the roles and the tasks are. Without the leadership in place to do that, we saw that things didn't work out all that well. And of course, somebody needs to pay for these new team members. And so if that money runs out, if there's not space for them to work or the things they need to do their job, resource-wise, that's going to get in the way as well. These, I think when you say them out loud, they sound quite intuitive, but they actually help us build a bit of a cookbook for how to do things better. Now, that's things we found in the literature, but we also have this natural experiment going on here in Ontario where there's been these rounds of funding that have gone out, as many of you know about, to grow teams to increase access and attachment. And we've started to try to identify bright spots, teams that seem to be off to the races with that money and doing new and interesting things, and trying to understand what makes those teams tick. Is there an overlap in these effective mechanisms to get them to increase access and attachment well? And so we have so far identified, actually not five, heading towards 9 teams. We visited them. We interviewed a whole bunch of the people in each of the teams, reviewed their documents, et cetera, tried to understand. These were basically case studies. And this is ongoing work. But preliminary findings, some of them are listed here on the slide, and there's some overlap, right? So, you know, in these teams that seem to be doing really, really well, they have leaders that are charismatic and engaging, and probably, you know, from a literature perspective, meet both the sort of transformative but also servant leadership kind of styles. They're really strong leaders that people respect and want to engage with. So that seems really, really important. It stood out to us. And that helped build this positive team culture where people are willing and able to adapt on the fly and share the load. And one of the things that we also noted is that there was a sense in these bright spots of things being done creatively, which is actually another word for differently. So people's roles weren't what they used to be. They're not what they are in the clinic down the road, or they're partnering in interesting ways with community services like EMS or that sort of thing. So there's, again, this is sort of adding to the possible recipe book of how do we do this well. A couple more items just to add is, you know, for those teams that are particularly focused on underserved or marginalized populations, there were some themes that are highlighted on this slide about teams that seem to be doing that well or focusing on it in interesting ways. And again, here you can see the community partnerships comes up, which again required that kind of leadership, the buy-in, and so on. And I just, you know, with an eye on the time, I want to skip ahead to the last sort of content piece, which was that Health Canada asked us to do a synthesis of evidence from, you know, Canadian studies and Canadian case examples to understand how primary care teams can work and what we can learn from that. And so just, you know, very quickly, how we did that was we took the Our Care standard plus a couple other established frameworks that have been out for a long time about, you know, what are the key elements of a high performing team. And we tried to synthesize what was common and what was distinct from those, because the concepts really in large part overlap. And when we did that, it spat out about 7 items that we think high-performing teams ought to strive for as they're doing their work. And those are on the right side of the slide there. Happy to talk more about this, but here's what it might look like. You know, teams that are, as they're striving towards accessible and timely care, maybe they're offering flexible scheduling. They share coverage for each other so that they can, you know, if somebody's away, it's not like their patients have to wait until they're back to be seen. So I don't want to read the whole slide for you guys for the purposes of time, but I'll just highlight the leadership and accountability bit that one of the things we found is that there's governance in place that doesn't micromanage, but does help set strategy, that tries to align the team's activities with the population need. And when we think about many of our teams, how well the governance is in place to help set strategy, and whether they have the data pieces in place to know whether they're hitting that strategy. It's something many teams in Ontario could strive to do better at. I would suggest. I'll just keep going because I know that we can come back to it, and I want to leave time for discussion. Just to highlight that when we put this piece together for Health Canada, we did a bunch of interviews again with key informants from a bunch of provinces and territories highlighted in pink here, or purple, depending on your screen. And you'll end up seeing some themes that feel perhaps overlapping with some of the stuff I said before, which I think is a good thing, because it's starting to get synthesized into some common elements that we can work towards in that recipe that I talked about before. So those are those 7 items on the right side of your screen, what we called key success factors from synthesizing those different frameworks. And of course, to get to those, we need policy alignment and funding in place. Obviously the people have to get hired somehow. But I just want to highlight that just because you hire the people doesn't mean you achieve those key success factors, doesn't mean you have a high performing, successful team. I think what's really crucial that we unpacked in this sort of output was that you have to think about the mechanisms by which that team can achieve those outcomes. And that means finding ways to share the load by having well-defined roles, by having trust, and by having the ability to adapt as maybe new needs come up or new data comes up that suggests a need for change. So these were the mechanisms that we saw in teams achieving those key success factors. I think another way of thinking about that is that these things, they interact, and they require purposeful attention. And so if we're going to share tasks effectively in the team so that we can sustainably provide comprehensive longitudinal care, we need to build trust purposefully in that team. That means creating time and space to interact with each other. Even if all the team members aren't in the same physical space, maybe they need to interact and get to know each other sometime. I mean, ideally, you can pick that person out of a line. But so interacting on Zoom or what have you, we ought to be measuring progress on how well we're sharing tasks and how well our patients are doing. And we should use that data to adapt to the needs of our populations, so we all feel a little less of that moral distress. We feel that this work is worth it. So that's where we landed in that paper, was that these are the areas to focus on if we're going to have effective teams, assuming, of course, we get the funding to hire those health human resources in the first place. What I can't tell you is what is the best model or the best ratio of staff. How many? That's what we often get asked. How many people should I hire? And we don't know. The literature doesn't tell us. The answer is it depends. And then the next answer is no matter how many you hire, what you need is to create you need some time and some purposeful effort to get those people working well together. As I said before, just because you brought on the team members doesn't mean they act like a team. And it really is that team aspect that allows for sharing of the load effectively. And there are some teams doing it really, really well that we can steal ideas from. And happy to talk more about that. I thought I would just try to fly through some of the stuff that's out there in the literature, some of the stuff that we've been working on. And now I think we can have a chat if you like.
Sure. Thanks, Noah. Maybe we get you to pull down the slides so we can see people. There was no comments in the chat, but that doesn't mean people weren't interested. But I'm just wondering if there's any questions or comments people want to put up their hand and ask Noah here first off. Tom, go ahead.
Thanks, Gordon. Yeah, actually, thanks, Noah. I'm actually a family health team pharmacist. I've been on probably 6 individual teams. Our family health team has 16 sites, and I've worked with probably 6 different provider groups. My latest one happens to be at a nurse practitioner clinic here in London. And I'll be honest with you, I think the recipe speaks to everything on that right-hand side on your slide, Noah. It's the buy-in, the trust, and what I think has actually formulated for us is that we're short 3 NPs out of 5. People have to do something else, and in all honesty, it's actually worked out better. It's actually solidified the team when people are, I'll use the word forced to trust. Really, they're forced to share the load, and then when they share those little meetings, again, we had weekly meetings just even for an hour to kind of, hash out, just talk about 2 or 3 patients you did together. What would you do differently? Why'd you do it this way? All those work out really well, but you have to buy in. You can't just give the IHPs who you don't want, because all you're doing is you're just keeping the old system. I think once you buy in, it takes time, but it works. So.
Thanks, Tom. I'm just going to take my chair liberty to ask you something. So I was thinking about the concept of trust that you talked about. You also mentioned the concept of at different times about co-location versus virtual. And then we have the concept of the core team and the enhanced team. So I'm just wondering, whether there's literature data or whether what your gestalt would be on the concept of, whether the core team, extended team, and the value of co-location in building trust and in building an effective team.
Yeah, so we absolutely did see in the literature and in our interviews that co-location helps. I think it speeds up the process. And I think I would say that for those teams that don't have the physical infrastructure, then they need to make up for that with added effort and probably added digital infrastructure for team building. So, whether that's a Zoom account or whatever, like I think the bottom line is like, then you're not running into each other in the halls. Ideally, you create other ways to run into each other or to have those meetings that Tom's talking about. Because I think it's so easy for some of us who maybe had a bad interaction or their patients had a bad interaction with somebody with that job profile before to not trust that a new person in that job profile can't take on the load from us. Like that makes sense. And somehow we have to give the opportunity for people to like learn a different way.
Neat.
Yeah, thanks, Noah, for all that. Yeah, like just that's some comments and thoughts, I guess, just about this whole natural experiment coming up with the IPCT stuff. It's somewhat natural, but it's somewhat not in the sense that we're all getting team members told we have to take on more people, regardless if that's what would be our choice or not, right? So it's somewhat like we're going to see great numbers of the team and cause people to attach more, but that was the mandate. We have to, right? So it's going to be interesting how that all plays out. I think for me, it's really, I think that the trust leap of faith part that we're talking about with our colleagues is that, that you're going to have these team members long term because people are well worried I'm going to take on 100, 200 more patients, but then I lose my person. Now I'm stuck taking care of these 200 more people. And then also the question is like, will this truly decrease my workload in the sense that if this new patient generates 4 or 5 visits per year, will my team members practically offset those 5 visits per year that don't require me to see them as well? Like if it's just an added visit, but they still have to see them the same number of times, then it doesn't really decrease the workload. It really has to take some of those visits off my plate, right? Whether it's a PAP, well baby, or whatever, but it can't be like I'll say the pharmacist is like having a pharmacist consult, but it doesn't actually, they never had that before. Now it's just an additional value add for sure for their care, but doesn't decrease my actual work because that may require, okay, they see the pharmacist, then they come back to see me to talk about that issue, and then it's going to added 2 more visits for me, right? So it's going to be interesting to see how it all plays out. And that's where the sales pitch is kind of tough for our colleagues sometimes because they don't see that, that it's going to reduce their workload. And if it does decrease the workload, they might just want the decreased workload without taking on the more patients, right? So it's going to be an interesting kind of couple of year, whatever, 2 years, whatever it's going to be.
I just think that was the most perfect comment ever. So everything you said is 100% true. Like there will be some of our colleagues that desperately just want some help and don't want more patients. Like they've been working 110 and they'd like to go down to 95, and that's pretty darn reasonable, if you ask me. So, you know, I'll just say that immediately. But I think the comment about, hey, if we don't think about carefully about what we're asking these team members to do, it may not actually help us decrease our workload. And that's what some of that literature I was trying to show, but I didn't say it as beautifully as you did, actually has shown. It is possible that it actually increases our workload or decreases our capacity because it just generates more visits. And yes, that's good for the patients. They're getting more care, but like we can only do so much. And so, you know, the recipe I really like to emphasize is as we bring on these team members, being really purposeful about what we're delegating, what we're how we're helping them work at their full scope so that they can take things off the plate, and then bringing patients along with that too, because the patients aren't used to that. And I think we have to think carefully about how we give patients the trust in that change as well. I don't know, I can't tell you exactly how to do that. I can just say that the teams that are doing that really, really purposefully, they're having success. You know, and it might require some iteration or adaptation over time, but they're attending to these things. And I think you raising the questions is just like that. It was perfect.
Other questions from our panel or for our members here today? Along that line that I'm going to jump in is because you're giving me some thought. We have with our IPTC funding, and as we're looking at implementation and everyone across the province who got funding this implementation, it's an interesting concept because we can look at, theoretically, we could look at what are the roles and responsibilities at a high functioning team members that could do that can increase attachment versus increase quality of care. And can we do both, right? And then can we do both without increasing administrative or time burden on the MRP that's taking them on? So those are the three variables I see, and how do we balance it? Or what do we do first that may allow increased attachment and not increasing the variable of time and burden on a provider? And then can we build in quality later? You know, knowing that we're really looking at a push for attachment. So to me, those are the challenges that are out there. And, you know, what is the immediate first thing that we could say? So for example, you know, Vineet mentioned how a clinical pharmacist doing a meds review could actually increase the workload, but a clinical pharmacist doing minor ailments would probably decrease the workload. So how do we utilize the resource in an effective manner to their capacity? So if a clinical pharmacist was working with your team and was able to see upper respiratory infections, UTIs, you know, conjunctivitis, et cetera, those type of things, or an advanced practice physical therapist, we've talked about that. I know during our, when we were doing our IPTC discussions back in April, could do, let's say, musculoskeletal assessments for the sprained ankle or the hurt knee or the back pain. That may increase your capacity in primary care. And as long as it comes down to, as Noah was saying, the trust, right? Do we trust that this individual is working at their capacity and that we trust their skill set?
Yeah, no, yeah, there are ways, you know, to think about, you know, Tom being able to manage, you know, the bulk of my Crohn's disease patients who have hypertension and diabetes and, you know, might need a little titration here or there, but they're relatively well controlled, and maybe only those that are, you know, it's a real head scratcher what to do next, you know, that's, but I will also add, hey, if I'm getting rid of all the easy stuff somehow, you know, that does actually make my day quite hard and stressful because now I have these long, complex, you know, without the in between, you know, easy fun visits. And I don't have a solution for that yet. I really don't. I just want to admit that's on my mind and it's something to think about.
Yeah, it's an interesting variable, you know, that that we have to consider. I appreciate that. Other
Like,
questions?
like I gotta say, I don't really want somebody to do all the well baby checks in my practice. Like, I really enjoy those, but there's no need for an MD to do
Yeah.
those. So these are tensions that are real, and we have to figure them out for the benefit of ourselves, but also the benefit of our existing patients who we want the absolute best quality for, but also the benefit of the population in and near our practice who currently get no quality of care because they can't access us at all. And how do we balance those tensions is really what this is all about.
Vala?
Thank you. We've been having some conversations about how do you like triage it up front so it doesn't have to go to the physician and then them determining who else on the team the individual could see. Like, do you have like suggestions for roles that kind of bring that more upstream so that they don't have to see the physician for certain things?
Yeah, there are models that are using, for instance, direct to physio for MSK problems, but it does need to have some algorithms. There are technologies also coming down the pipe at Colin that can direct people to the right path that we should probably be on the lookout for. I'm not sold that they totally work, but it does require upskilling often the person picking up the phone if we don't have the technology. And we have to just think that through really, really carefully. It's something in my own practice we're struggling with, because the phone calls sometimes go to the nurse and it should have gone to me. And sometimes it goes to me and it definitely should have gone to the nurse, or maybe the secretary should have done it on her own. I don't know, but it's absolutely an important place to focus. How we upskill what we're calling medical office assistants, what in some offices they would call a medical secretary or what have you. I think it's an area where we actually have some active research going on right now, and we can share with you, if it's of interest, some early findings about opportunities there, because I think it's a need.
Then no, there's the learnings that Tara has done from the Netherlands on the I forget they're not called physician assistants, but they're the individuals who are the first contact of the phone, but they're quite highly trained,
Yes.
almost an RN level to really do good triage. And I think it's very different than we see our medical office assistants being trained, which is more administrative training. And so, can we create a better first contact triage system, right? And obviously that's a system level process that would have to be looked at, but it's an interesting concept of what's different in other jurisdictions that we can learn from.
Yeah. And I believe those medical assistants, I'm not sure, but I believe they are regulated as well. Like they're a profession. Whereas
Yeah.
our medical secretaries or medical office assistants or whatever you want to call them, they're unlicensed. They're just the people we happen to hire, and hopefully we train them okay. And it's a little bit of a Wild West.
Any further questions? All right, with that pause, then I will want to thank Noah for coming today and providing that input, and I appreciate everyone's input and discussion. As mentioned, we are recording this and we'll have Noah slides available at a later date on the MLPCN website. So thanks very much, and I'll let everyone get on to the rest of their day today. Thanks.
Bye-bye.
Thank you.